الله وبركاته. مساكم الله بالخير. الليلة إن شاء الله مركز المشفى الصحي ننظم فعالية، مجموعة محاضرات تتعلق بقصور أو ضعف عضلات القلب وعلاقتها بكهرباء القلب. يشاركنا اليوم الدكتور سعد الحسنية من جون هوبكنز أرامكو، دكتور طارق الحقباني أستاذ مساعد في جامعة الملك سعود، دكتور حامد الغامدي استشاري الشرايين والأوعية الدموية. نتمنى إن شاء الله أنها تجد القبول والاستحسان وتعم الفائدة للجميع بإذن الله.
السلام عليكم ورحمة الله. أنا سعد الحسنية من جون هوبكنز أرامكو، تخصصي هو كهربائية القلب، وحضرت المؤتمر هذا طبعا للتوعية بمرض معين اللي هو توقف القلب المفاجئ وضعف عضلة القلب، وفائدة تركيب الأجهزة الصاعقة والداعمة والمساعدة لتقوية عضلة القلب.
أنا الدكتور محمد إسماعيل الخرساني، استشاري أمراض القلب بمستشفى الملك فهد التخصصي بالدمام. اليوم ولأول مرة أنتهز هذه الفرصة لأحضر مثل هذا اللقاء الهام العلمي لأمراض كهرباء القلب وتعلقها بفشل القلب، وهما مرتبطان معا. وهذا اللقاء هام جدا في معرفة مثل هذا الخلل. وطبعا في هذا الخلل طبعا قد يتم علاجه أيضا بالأدوية، أو قد يتم علاجه بالقسطرة الكهربائية التي يقوم بها الزميل موسى الحربي في المشفى العام. طبعا اللقاء هام، وأتمنى من الكل الحضور والاستفادة من هذه الفعالية.
دكتور محمد رمضان، المدير الطبي المركز المشفى الصحي أو المشفى هيلث سنتر. النهارده ده تاني انعقاد للمشفى ميديكال كلاب. كنت حابب ان انا اوضح ايه المشفى ميديكال كلاب. هي فكره عباره عن كل تخصص شهريا هيقدم كل التطورات العلميه لهذا التخصص. يعني الشهر اللي فات كان اول انعقاد لمركز المشفى الصحي، كان قسم جراحه السمنه، وكان بصراحه شيق للغايه. استفدنا كتير من المعلومات الشيقه او المعلومات المفيده اللي ظهرت، وكان في الاطباء برضو من جميع انحاء المنطقه الشرقيه بالمملكه بيشاركوا بعض الافكار واخر التطورات واخر التحديثات في عمليه السمنه. شهر ده ان شاء الله قسم القلب دكتور موسى الحربي استشاري امراض القلب، ودكتور حامد الغامدي استشاري امراض القلب مركز المشفى الصحي. النهارده انعقاد لقسم القلب، والنهارده هنتكلم على مواضيع تخص كهربائيات القلب وفشل في عضله القلب وايه التحديثات. فكره المشفى ميديكال كلاب هي مشاركه الافكار ما بين الاطباء بانحاء المنطقه الشرقيه بالمملكه، ودي اللي بتساعد كل طبيب اللي هو الاطباء الصغار او الاطباء في تخصصات مختلفه، اللي هو يقدر يشوف ايه اخر التحديثات بالنسبه بخصوص كهربائيات القلب وفشل في عضله القلب. ان شاء الله هتكون محاضرة رائعة. معنا الدكتور حسن حسنية والدكتور طارق الحقباني، ودول أطباء من خارج المملكة شرفونا النهاردة كمحاضرين في المشفى ميديكال كلاب بخصوص أمراض القلب. إن شاء الله تكون محاضرة رائعة، وإن شاء الله الشهر الجاي أنا بحب برضه أنوه للشهر الجاي إن شاء الله هتكون محاضرة قسم الغدد الصماء والسكر، ودي هتكون إن شاء الله يوم 24 مارس، وهنعلن عنها، ويا ريت نكون بنفيد بالمعلومات الجديدة اللي بتتقام بخصوص المشفى ميديكال كلاب الشهرين. شكرا.
Once again, thank you so much for coming out. I know it's hard to come out in the middle of the week. It's glad to see so many faces I haven't seen for so many years. My name is Hamid Al-Ghamdi. I'm an interventional cardiologist from the Eastern Province. Currently working at the Mashfa Clinics, which is a specialized center for those of you who don't know it. We're glad to share with you a very special program tonight. The Mashfa Clinic has started a series of clinical or medical activity a couple of months ago, and it will be done on a regular basis. One of these activities will focus on cardiac updates. And tonight we're glad to have three very distinguished electrophysiologists from the region and from outside the region to share with us some important topics in the update electrophysiology.
He's known to have paroxysmal atrial fibrillation for almost 18 months.
had mild LV dysfunction with ejection fraction of 40%. He was anticoagulated with rivaroxaban, and he was on Concor 5 milligram. He was tried on Sotalol for a short period of time, but he was intolerant. This is his ECG, and you can tell he is in atrial fibrillation. He's more now persistent atrial fibrillation. My question to all of you, what would you do with such a patient? You put an amiodarone? Would you increase his bisaprolol dose to 7.5? Would you consider pulmonary vein isolation? Or would you just do elective cardioversion and continue with Concor? We'll let you think about it. We'll come to this case at the end of this presentation. What about atrial fibrillation? It's another common arrhythmia type. It's responsible for at least 1/3 of all admissions related to heart rhythm disorder. And it's also prevalent in patients with advanced age. Does atrial fibrillation and heart failure come together? Yes. If you look at Framingham study, where they look at patients who presented with newly diagnosed heart failure, so they looked between the year 1999 and 2012, they noticed that more than half of the patients, so 57% of patients with a newly diagnosed heart failure, they will come with atrial fibrillation. And we know from all the clinical trials that done in heart failure that atrial fibrillation is actually more prevalent with the stage of heart failure. So you go from 5% if you are functional stage 1, or in terms of looking whether they have persistent or paroxysmal type of device they have. It's actually all in the favor of catheter ablation. One thing I want to point here is LV dysfunction. So if your EF is below 25, it seems that you don't get much of benefit from catheter ablation. That's something that we need to consider, because if you want to consider this procedure, you have actually to do it somewhat earlier. Let us say 25 to 35. If you wait till they are atrial failure, which is basically all this atrial disease that will end up with symptom of heart failure in the absence of valvular heart disease or LV dysfunction. Okay, I would advise everyone to go and try to read it and understand the concept, because we tend to ignore the atrium as part of the problem. But I think there is a lot of atrial disease that has to be addressed early on in the process of heart failure. Now, back to my case, this is the 36 years old with shortness of breath, paroxysmal atrial fibrillation, mild LV dysfunction. He is in rate control. This is his ECG. He's more persistent atrial fibrillation. What would you do for this patient?
Thank you, Dr. Musa. This is very, very important and interesting lecture. My question is, patients with atrial fibrillation and heart failure, both of them have vicious cycle. Either heart failure causes an atrial fibrillation, or atrial fibrillation the cause of heart failure. I mean, in this case, suppose that the heart failure is the reason for the, are you going to treat even heart failure, so that otherwise, in the future, the patients can develop atrial fibrillation again in case you ablate this patient?
I think it's what we need to do when you have heart failure and atrial fibrillation. This is the way I look at it. Okay, whether it's atrial fibrillation or atrial arrhythmia. Okay, you have to do something to help this patient. Okay, so either you treat the heart failure. Okay, you do aggressive with heart failure and see what will happen, or take the arrhythmia out of it. Now, most of the time,
move on to our next speaker, Dr. Saad Al-Hassaniya. Dr. Saad Al-Hassaniya is the chairperson of cardiology and cardiac surgery at Johns Hopkins Aramco Healthcare, and he will talk about the role of cardiac devices in atrial fibrillation. Yes. Dr. Saad.
Introduction, Hamid, and I really thank المشفى Medical Center for organizing this night and recognizing EP with such a special night. We always hear about Echo Club and Cath conferences. So hopefully this will set the floor for more future regional EP meetings. So I'll talk about the magnitude of the sudden cardiac arrest in patients with cardiomyopathy, ICDs, which is the internal cardioverter defibrillators, the indications and the risk stratifications, which patient should we offer ICDs, and other high-risk groups, and we'll also talk about the cardiac resynchronization therapy indication and benefits. I will focus on the primary prevention. So primary arrest, most of the arrhythmia are monomorphic ventricular tachycardias, up to 62%, with others mean for bradycardia, polymorphic VT, as well as a primary VF. So most of these arrhythmia can be treated or intervene upon early in the course of the arrhythmia, and patient will survive it. What are the substrates for sudden cardiac arrest? Which patients are at risk for sudden cardiac arrest? Prior MI is number one and recognized factor identifying patients for future sudden cardiac arrest. These arrhythmias, when there is a scar in the heart, can form a re-entry arrhythmia around the survival, increase mortality, even in normal left ventricular function patients. Usually the myocardium receive the electricity from the posterior wall and from the septum through the left posterior, left anterior, and the electricity will move to the lateral wall as well as the septum, and this will create more of a synchrony in the contraction between the lateral wall and the septum. With the left bundle branch block.
Do a pacemaker? No one?
Keep an eye on Dr. Musa Harbi and Dr. Halbani.
You're allowed to participate. Can you go back to the ECG?
Okay. Okay. So what's the diagnosis here? Okay.
Okay, let's go back to choices. So again, do a pacemaker with pacing. Anyone? No one. Do a pace chamber ICD. No one. Okay.
Thanks for the invitation, Musa, and to Mishwa Sahi. So we'll take this presentation probably 10 to 15 minutes maximum, and the topic is really easy, it's not complicated. It's straightforward points, and we first would like to take this case first. And I learned a lot from this case, and hopefully you will. This is a 22-year-old male, fatigued and shortness of breath on exertion. His heart rate in the clinic on the initial visit was around 120. This is his ECG, and you can tell there is tachycardia. And there is a positive deflection here in V2, and there is a deflection here, deflection here. So what are the possibilities here? We have heart rate of 160 here or 150. We rarely see this in males, mostly in females. But that's a possibility. The second is atrial tachycardia, which is known to be persistent or incessant. It can come in that way, or it can be paroxysmal with episodes, but paroxysmal episodes. So this is my differential diagnosis at the beginning: inappropriate sinus tachycardia or atrial tachycardia. The patient actually was seen at different hospitals, and he had echocardiography at one time and showed ejection fraction of 25%. So we're talking now about something more serious. It cannot be just inappropriate sinus tachycardia, which is not known to cause LV dysfunction. It's not known to cause LV dysfunction. What about the rhythm? The rhythm is still abnormal. The P wave here is clearly negative and can't move the arrow. Here in lead 3, it's clearly negative, as well as in V1. Also, it is mostly negative, which can be due to atrial abnormality. But it's clearly negative in the inferior lead, which is lead 3. So the rhythm is still not normal. Despite controlling his heart rate, the rhythm is still abnormal. The ejection fraction persists to be impaired. The ejection fraction is 25 to 30%. He had multiple echoes over years. His ejection fraction was severely impaired. Patients come with fatigue and shortness of breath, not by palpitation. Many of them, they don't have palpitation, but they come, they present you to the clinic with shortness of breath and fatigue. Okay, because of this, the actual perfusing cardiac output to the tissue is less than the number given by the ECG. So this is not related to our actually main topic, but it's very important to mention. So the best option of treatment, we start beta blocker and follow up. Flecainide. Why not flecainide? We don't have it. Yes, it's difficult to get in Saudi Arabia, but here in the eastern region, you have Bahrain. Many people, they go to Bahrain and get the flecainide.
July 2019, she came with a shock from her device, and we switched her beta blocker to Cetolol. Then in October, she came with this. So if you are not familiar with this is the plot analysis where you look to the heart rate. She's tachycardic. The device recognized that. Try to stop it with anti-tachycardia pacing multiple times. Failed. Shocked the patient. Okay? She got to the emergency. She had multiple episodes of palpitation and shock. And while she's in the emergency, she had this. So she had ventricular tachycardia that is actually below the detection rate of the device. So let us say the device is 180, this rate is 170, so the device will not treat it. Okay? So what would you do with this patient? Would you stop Cetolol and carry on with amiodarone? Thank you. I will try my best to make it simple. So recurrent ventricular tachycardia, how to manage. This topic is of personal interest. So I did extra 1 year of complex arrhythmia, including ventricular tachycardia. So some of the clinical trial that I'm going to mention today is I took either part or was, the fellow is recruiting patient for those clinical trial. And I will try to simplify it. So I will tell you what is the relation between ventricular tachycardia and sudden cardiac death. How would you manage a scar-related ventricular tachycardia? And how could you deal with idiopathic? So let me share this case with you. This is one of my patients, been following now for 2 years. She's 35, mother of 3, lady with a scleroderma. She had mild RV dysfunction and frequent PVCs. She had a lot of investigation for her RV dysfunction, whether we are talking about PVCs, non-sustained ventricular tachycardia, or sustained ventricular tachycardia. It has to be actually, you look at that based on the presence or absence of abnormality in the heart. So is the patient heart normal or abnormal? So if it's abnormal, this is most of the scar-related ventricular tachycardia. And this is basically the majority of ventricular tachycardia, more than 90%. There is 10% of patients that they have idiopathic, and Dr. Tariq mentioned some of those patients that come with PVCs, RVOT PVCs. They could come with RVOT VT. Those are different patients, normal heart, and the treatment is different. So what would you do when you see a patient who's coming to you with this? This is a why.
Thank you so much, Dr. Musa, Dr. Saad, and Dr. Tariq, and thank you everyone for coming tonight. Before I conclude, I'd like to thank our partners from Medtronic, whom their generous educational support made this meeting and other meetings possible. Thank you so much.
My name is Dr. Mohammed Ramadan. I'm the medical director of Mashfa Health Center. I would like to thank you all for your attendance and thank you for Medtronic company for sponsoring this nice cardiology gathering. Also, I would like to announce about the next gathering. It will be held on 24th of March. Will be the endocrinology department and the endocrinology team will take care of this meeting. It will be next month, 24th of March. We will have hot topics in diabetes, like management of type 2 diabetes in elderly, and anti-diabetic medication and the new cardiovascular.
الله نشكر المستشفى المشفى لإقامة هذه الفعالية المهمة جدا لأمراض كهرباء القلب، وهي فعالية تنبه العديد من الأطباء في المستشفيات الأخرى بالتقنيات والتطورات الحديثة في هذا المجال، وهذا ينعكس بالفائدة على المرضى. فالشكر الجزيل للمستشفى الصحي على هذه الفعالية ورعايتها، وهم أهل لذلك لما يمتلكونه من خبرات وتقنيات عالية جدا في هذا المجال.